Okay, so we had a misfire with the recording technology yesterday, and I think that may have been my fault. So I'm going to go ahead and this time record an abbreviated version of what we actually did in class to replace what was lost. This will not be a perfect replication, and it will be shorter. But it should give you some of the key points that you need to know that if you missed class yesterday. All right, so this is the quad model that we've been talking about in class. So I reviewed this a bit. The quad model begins with, or should begin with, the patient. Doesn't really in the book, but the way I see it is it begins with the patient. And the question is, the first piece of the quad model is financing. So where does the money come from to pay for healthcare? And so financing is, where are the resources to cover the costs coming from? And they come from, generally speaking, three places. First, you as an individual pay part of all of the healthcare, right? So think about, even if you go to see a physician, you typically pay a copay. That would be part of you contributing to financing. You also pay an insurance premium. Even if you have employer covered insurance, you also pay a piece of the insurance. So that's also coming from you contributing to this kind of big pool of financing. The government, even if you have private insurance, the government is contributing and subsidizing your healthcare in a variety of ways. We're going to discuss some of them as we go through the class. So even if you have private insurance and you're going to a private hospital or private physicians, the government is still contributing to that. And then finally, your employer contributes to financing. So most people in the United States who have commercial health insurance have it through their employer, and your employer subsidizes, again, the overall financing of your healthcare. Now, where does the government get its money? Well, it gets its money in the form of taxes, right? From both you as an individual. So you pay income taxes to the government, and then your employer pays corporate taxes. That's basically where the government gets all of its money. There are some other taxes, such as fees, that the government charges for various things, but the vast majority of the government's financing is in the form of, most of it's individual taxes, and then corporate income tax. So the government doesn't earn its own money, right? The government takes money from individuals and employers or corporations in the form of taxes, and then contributes to the overall financing of healthcare. So in, say, the British model, where everything is paid for by the government, the employers don't pay directly into the financing. They just pay taxes to the government, and then the government does all the financing. Okay. So we have financing, and so some of the money come, particularly, say, for you, let's say if you're paying for your own care directly, your money would go into your financing pool. Then we would go over to the payment mechanism, and then it would pay the provider who would deliver the care. Right. So we have this. You also purchase insurance, and that's where I spent some time in class on talking about insurance, right? Because insurance is not the same thing as healthcare. Having health insurance is not the same thing as having access to healthcare. Now, one of the things I talked a little bit about the nature of insurance in class. So I distinguish between what I call true insurance and prepaid expenses. So what is insurance really meant for? Well, it's really meant to cover catastrophic losses that are unpredictable and randomly distributed. Right. So true insurance covers catastrophic losses and unpredictable and randomly distributed losses, right? So again, they're catastrophic losses that you can't predict, and they are randomly distributed in a population. So insurance is not prepaid expenses. So the example I talked about in class kind of at length was the idea that most of you have cars, and so you have auto insurance. And there are two kinds of typically, I mean, there's a number of different kinds of insurance you can buy from your insurance company, but the two big ones are liability and collision. So liability covers if you get in an accident and you cause harm to someone else, right? The liability portion of your auto insurance covers the harm that you do or you are responsible for to someone else. So if you get in a car accident and you cause $10,000 worth of damage to someone else's car, your liability insurance is going to make that person financially whole by giving them a check for $10,000. Now that for you and even for me, at a more advanced stage in my life, I could cover $10,000, but I really, really wouldn't want to. It would still, to me, $10,000 would be a catastrophic loss, right? So I want to be insured against losses of, say, $10,000. But and what a catastrophic loss is depends on your own financial situation. So, as you get older and more financially established, you'll be able to sustain more losses that would be catastrophic to someone with very little income, are not catastrophic to someone who has significant savings. So if, Bill Gates, one of the richest men in the world, founder of Microsoft, was to get in a car accident, and he had a $10,000, he caused $10,000 worth of harm, he could basically just, charge it to his credit card and not even blink, right? Whereas you or I, that would be a major expenditure. It would be of significant harm to us. So we would want to insure against catastrophic losses. So typically a liability insurance is 100, 300, I think is kind of a standard. So per incident, per individual involved, your insurance will pay up to $100,000 with a $300,000 cap. So if you harm more than one person in a single accident, you're up to $300,000. So don't hit anybody driving a Ferrari, because that'll run down your insurance real fast. Okay, so you have liability insurance, and then you have collision insurance. So liability is to protect or to help you cover the costs of harm to someone else. Collision then is insurance for your own losses if you are in a car accident. So if you have a nice car that's worth, say, $10,000 or $20,000, or when you graduate and you get that fabulous new job and you go out and buy yourself a new Mercedes and it costs $50,000, you're going to want to have collision insurance, because if you get in a car accident and all you have is liability and you wreck your $50,000 car, if you don't have collision insurance, you'll have that $50,000 loss, which definitely for me, and I'm sure for you, would be a catastrophic loss, right? It would be a life-changing event. So you want to have collision insurance if your car is worth a lot of money, because if you get in an accident, the insurance company, and you total your car, your insurance company will pay you whatever the market value of your car is. Collision insurance only makes sense, though, if your car is actually worth something that would be a catastrophic loss to you. So the example I use in class that I like to joke about is I drive my wife's old minivan. So I bought off the lot back in 2004, a very nice Honda Odyssey SE 2004, and it was a fabulous, beautiful car at the time. Um, and eventually, my wife decided she needed a new car, so we bought her a new Pilot, and I inherited the um, Honda Odyssey, which I am still driving. It has almost 190,000 miles on it. The doors, the sliding doors that used to be automatic, don't work anymore. So they're manual. They usually close after a couple of tries properly. They usually open if they're not frozen. So, and it's pretty run down. And if I was to try to sell that, I might, be able to get $1,000, probably less than that. So I have liability insurance on the Honda Odyssey, the 2004 Honda Odyssey. That's 18 years old this year, right? But I don't pay for collision insurance because I typically have a $500 deductible, and the market value of the car would probably be somewhere in the $500 to $1,000 range. So let's say it's worth $1,000. It's actually worth more than that to me because it gets me around perfectly fine. Engine is in great shape and it runs great. My wife just hates it and wants me to get rid of it. My kids won't be seen in it. But I tool around in it all the time. You'll see me around campus and around town driving it. I got big yellow. It's a silver Odyssey with big yellow kayak racks on top of it. It's hard to miss if you see me around. So I don't bother with collision insurance because a loss of $1,000 is not a catastrophic loss to me, right? Now, maybe a loss of $1,000 would be a catastrophic loss to you. So I don't insure against collision or collision loss on the Odyssey. And someday, when it finally dies, I plan to get out of the car and walk away from it and not look back. So the point is, true insurance is designed to cover catastrophic losses. You should not insure things that you can afford to replace. So like if you go to Best Buy and you buy like a $50, pair of headphones, they will offer to sell you insurance, right? Replacement insurance or something like that at the exit when you check out. And they'll typically say, would you like to insure this for 3 years for, $12.99? And the answer you should give, generally speaking, should be no, because $50, even for you as a hardworking but poor college student, is $50 is probably not a catastrophic loss. So you just need to be careful with your $50 headphones. Now, I want to talk about prepaid expenses because health insurance is the combination. When we talk about health insurance is really true insurance plus prepaid expenses. And that's why health insurance is so expensive, is because there is a component of catastrophic loss insurance in health insurance, but there is also a large chunk of prepaid expenses built in. So let's talk about prepaid expenses from the perspective of auto insurance. So your auto insurance company does not offer gasoline insurance, right? They don't cover gasoline for you, meaning they don't offer to say, hey, buy this, in addition to your liability and your collision plans, we're going to offer you a gasoline use plan. And so whenever you go to the gas station, instead of putting your credit card into the gas pump, you're going to put your insurance card in the gas pump, and you'll pay, say, 25 cents a gallon. And then the rest of the cost of the gasoline will get billed to the insurance company, and then the insurance company will pay the gas station at the end of the month for all of the difference between what you paid, your copay on the gasoline, and what they and the actual price. So if the price was $3 a gallon, for every gallon, you'd pay, say, 25 cents, and then 275 would be billed to your insurance company at the end of the month. And so you'd have some sort of premium, right? That's what this is called. A premium is what you pay each month to your insurance company that would cover the liability, the collision, and now your gasoline insurance. And so they might say something like, hey, you can have gasoline insurance for $50 a month. And, you just go use gasoline. And we'll, we'll pay, you pay 25 cents a gallon, we'll pay the rest. And so what I said in class was, if you've heard that deal just now, you're probably clicking through in your head, how much do I spend on gas each month? Right. And if it's less than $50 a month, then you wouldn't want to buy the gasoline insurance program. But if it's more, then you'd be like, oh yeah, that's a great deal. I'm definitely going to do that. And so, and even better, if you currently spend less than $50 a month, now that you know that that you can have basically unlimited gasoline for $50 a month, maybe you'll start driving your car as an Uber driver, right? And have the insurance company pay for all of your gasoline that you're using to drive and earn money, right? That's that behavior where, when you're no longer bearing the cost of your actions, and you start to increase the amount of cost as a result, because you're not bearing the cost, someone else is called moral hazard. And we'll talk more about some of these economic concepts for insurance. But moral hazard is a critical issue that insurance companies constantly worry about, because if they offer to provide to indemnify you, that's the formal word for when they transfer the cost from you to them, they worry that you'll start behaving differently than you did when you didn't have insurance, and you'll start transferring more risk to them. Okay. So that's why, insurance companies know perfectly well that that's what you would do. So, they would not charge you. They don't do this gasoline insurance program. However, health insurance, we do that, right? And so with health insurance, we have, we have the true catastrophic losses. That's the true insurance. So that's like coverage if you break your leg, right? If you break your leg, it's a probably $10,000 bill, right? And if you get a bad break, it could run upwards of $75,000 or $100,000. That's a catastrophic loss, right? But picking up your birth control each month, for example, which is a requirement under the ACA, the Affordable Care Act, the full name being the Patient Protection and Affordable Care Act, also known as Obamacare. We'll generally refer to it as the ACA, but you may hear it as the PPACA, the Patient Protection Affordable Care Act, the Affordable Care Act, or Obamacare. Those are all the same thing, right? So we'll generally shorthand it as ACA. The ACA said that certain preventative services have to be included in the premiums that people pay for insurance. A lot of people say, well, now those services are free. Well, that's actually not true, right? What happens was, when those things were not covered by insurance, or they were covered with a copay or so forth, the premiums were lower. But once birth control is a covered expense, that it has no out-of-pocket expenditure, meaning you as the covered individual do not have to pay any cash at the time that you get the service. That just means that the insurance companies pushed that into your premium. So if your premium was, say, $500 a month, and they used to not cover, let's say they didn't cover birth control, and birth control was $25 a month, and now the insurance company has to cover birth control at no expense to you, then your premium is going to increase by not just the $25 per month that the cost of the actual birth control. It's going to be more like $535 a month, $25. And you're like, why is it not 500 plus 25? Why isn't it 525? Well, because the insurance company has the cost of paying for the pharmaceuticals or whatever your birth control method is. And they have a processing cost of handling your claim and then paying the bill. So the cost when we pull things into the premium and make them free, and I'm using scare quotes here, free to you, it's not really free. It's just getting rolled into your premium. So sounds good, but in reality, it just drives up costs. So all right, so that we covered, that was kind of an important piece. Then I talked about also from the ACA, right, the Affordable Care Act, the ACA, a number of things were integrated into, a number of preventative services were integrated into your premiums. So they were no longer, insurance companies had to pay for them, and they had to provide them at no out-of-pocket expense to the insured member. And so what they did was they pushed all of those into the premium. So those things, some examples of that are birth control, which I already talked about, annual physical exams, mammograms, I believe colonoscopies, which is not diagnostic colonoscopies, but screening colonoscopies. So I joked about this, I don't know, 2 sessions ago. You know, when you turn 50, one of the great pleasures is you get to schedule your first screening colonoscopy. So things like that get pushed into the premium, and they're no longer things where the insurance company can say, well, you have to pay a piece of it. And so that just drives up that it's a shifting mechanism. And there are good arguments for that. When people perceive that they've already paid for it, they're more likely to get it. And some of these things are really useful. Another example would be really important right now would be immunizations, right? So those are considered preventive measures that the insurance company is not allowed to charge you anything out of pocket for. Now, another really important thing that changed was the mechanism whereby premiums, right, the amount that the insurance company charges for your health insurance changed. So it used to be that premiums were determined through a process called experience rating. And this is where car insurance is a useful example, because car insurance is determined by experience rating, right? So if you get in a car accident, what happens to your insurance premiums for your car insurance? Well, they typically go up. If you get a speeding ticket, they typically go up, your insurance costs. I'm trying to think of what else would when you're young, the insurance costs are higher, and as you get older, they go down if you have a good track record. So what the insurance company is doing is they're taking their individual experience with you and making a determination of how risky you are. And then they determine the premium, right, that you will be charged each month or every 6 months or however you pay it, right? They determine their premium based on their individual experience with you. Well, health insurance used to work the same way. So if they'd do an exam on, to get health insurance, if you are buying it in the individual market, so for health insurance, you used to have to get a physical exam, if you were getting a new one, a medical history, which would be included in the physical exam. And these two things would be used amongst other factors such as your age, sex, do you smoke? Do you admit to doing drugs? Do you have a hobby of parachuting, right? Things like that were all integrated into the your premium, right? So the insurance company would look at all these things, and then they would decide how risky you were to insure for your health insurance. How likely was it that you were going to have a catastrophic accident? How likely was it that you were going to have, say, a baby, right? So young women of childbearing age paid higher premiums, health insurance premiums, than women who are postmenopausal, because having a baby is expensive, right? And postmenopausal women can't have babies. Um, so, so they would charge young women more than older women. Um, and then, if your medical history included things like being a cancer survivor, right, or you have a chronic disease like diabetes or asthma, you would get charged higher premiums as a result, right? And in some cases, they would say, if you had, if you came down with cancer and then they'd pay all those expenses, and then you went to renew your health insurance, they'd say, hey, your medical history has changed, and so based on our experience with you, we're adjusting your premium, and now it's going to be 4 times what it used to be, right? At which point, because you're a cancer survivor, and it's likely that you're going to have cancer again, we have to charge you 4 times as much as we used to. Uh, and a lot of people would get priced out of the market at that point. And then they would wind up not having insurance at all. And then if they got sick, they would have a catastrophic loss, right? That they could not sustain. So this was a problem pre-ACA, right? So before the ACA, health insurance was run on an experience rating methodology. Now, that's the downside of experience rating. The upside of experience rating is if you're young, healthy, you can prove that, through the physical exam, they can tell that you're in good shape, right? You have a very low body mass index, right? Meaning your ratio of fat is very low. So maybe you're like a 3% body mass index, right? That tells me, right? BMI is what that. So that tells me that you're healthy, right? And so people who had good medical histories, right, got lower premiums. So, but the ACA, so the ACA said, when the ACA was implemented, they did away with experience rating. They said no more experience rating. Instead, we're going to have what's called community rating. And what community rating means is it's based on geography. So the basic fee is based on geography. So the premium is going to be based on what is how sick is the average person that lives in Durham, right? Or the Seacoast area, or whatever, however you draw the geographic area, right? They look at average expenditures per person, and they decide based on everybody who lives, right, in this area, depends on, if this area is relatively healthy. If everybody in this area doesn't spend a whole lot of money, then you get a relatively low premium. If you live in an area with a lot of obese smokers who drink too much, then your premium is going to be really high. But so community rating takes out the individual. So instead of looking at Joe here and Sally here, we look at everybody who lives in a particular region. We're allowed to adjust. The insurance companies then are allowed to, they have to charge the same premium to everybody with a couple of adjustments. They can adjust for age. They can adjust it. They can ask you if you smoke. And I believe sex. I have to double check that, but it's a very, very limited number of things that they can ask. They cannot ask you, your medical history as an individual, right? So no medical history. They can't ask any pre-existing conditions, which is part of the medical history. So none of that, right? So if you've had a heart attack, they can't take that into consideration. If you've had cancer, they can't take that into consideration. If you have type 1 diabetes and you have to take insulin every day, they can't take that into consideration, right? All they can take into consideration is your geographic location, your age, whether you smoke or not, and I believe your sex. And they can adjust based on those three factors. Now, what happens? Well, we had under experience rating, let's say Joe paid, Joe is in good shape. He paid $100 a month in premiums because he had a healthy medical history. He had no pre-existing conditions. He appeared to be he appeared to be in good shape. And then we have Frank, who is obese, smoker, didn't get any exercise, has a heart condition, asthma, and type 2 diabetes, which is diabetes you acquire because your pancreas gives up on you because you eat so badly, amongst other things. Frank was paying $800 a month under experience rating, right? Because Frank's in bad shape, Joe's in good shape. Big difference between the two of them. Let's assume they're the same age. So maybe they're both 50, like me, right? Joe runs marathons. Frank watches marathons on TV. Sometimes it kind of exhausts him. So he goes back to watching the Great British Baking Show instead, and drinks beer and eats cake while he does it. So under experience rating, the insurance companies could charge these guys different amounts. Under community rating, Joe and Frank, and they're neighbors, right? So they live in the same geographic area. Joe now pays $500 a month, and Frank pays $550 a month because he admitted that he's a smoker. And so he pays a slight premium. So that's the new norm under the ACA. And what people found was that their premiums overall went up. People like Frank, who were already paying a lot because they were in bad shape, saw their premiums go down, right? But most people saw their premiums go up. On average, people's premiums went up, not just the Joes who were super good shape, but just your average Joe. Your average Joes saw their premiums go up, not just your super Joes, right? So that's the result of community rating, because you can no longer distinguish between the people who take good care of themselves and the people who don't. All right, so that was kind of wrapping up chapter 1. Now I'm going to go ahead, pause here for a second. All right, so now I'm going to get into the lecture slides. So we're doing chapter 2. So the question now with chapter 2 is we're looking at the kind of socio-cultural determinants of health. So what is health? Well, in the US, we've historically thought of health from a medical model. And under a medical model, health basically means freedom from disease and illness. And so we ask a question, well, what do we mean when we say illness and disease? And so I want to suggest, and this is, if you talk to a doctor and you said, hey, what's the difference between illness and disease? They're probably not going to have these definitions, but this is a useful model I found in an anthropology journal talking about the two. And we'll use this for this class, right? And the reason we're going to use this kind of model of this idea of differentiating between illness and disease is because it's useful. And we do a lot of that in social science. So when we talk about illness in this class, we'll talk about illness as a feeling that an individual has about their own health, and how we'll define that is when they infer diminished capacity to perform the tasks and roles that that are expected by society. So if you wake up in the morning and you say, I can't go to work, Well, that would be a diminished capacity to perform tasks and roles, right? I can't go to work because of something I'm feeling, right? So that could be because you're running 104 temperature. It could be because you have strep throat. It could, all of the above as COVID, right? Those would be you making a decision about yourself. And so this is an internal, meaning you're the one making the decision, and it's a subjective judgment, right? This is your judgment. So subjective versus objective. I'm not relying on some external tool. I gave the example of the temperature of 104. That's an objective measure. But if you say running a temperature of 100, what is it that keeps you from being able to work? Some people could probably work. Maybe they could work from home with 102 temperature. You wouldn't want to go into the office because you're probably contagious. But you basically, under illness, it's the individual person's perspective, right? Disease, what we're saying is this is based on a professional evaluation. So you have a disease because a doctor says you have a disease, or a psychologist says you have a disease, or a nurse practitioner, right? So it's based on some sort of social figure who has power to make this decision and say, you, from society's perspective, you cannot perform your tasks and roles that are expected by society. So we're going to circle back to this in a minute. So, but the idea here is it's possible for you to feel like you have an illness, right? For you to feel that you have a diminished capacity to do whatever it is you're supposed to do. So maybe you as a student, right? You can't go to class. You as someday when you're a spouse, you can't perform your spouse duties, whether that's, cooking dinner or washing clothes or whatever, or you can't perform your roles as a parent, right? When you eventually have children, right? Those in that situation, you would have an illness. For you to have a disease, a socially determined person with the power, a social authority, has to say that you actually have a disease. All right. So we'll circle back to that. Now, disease states. So we're focused on things that are observed outside, from the outside looking at you. 3 levels of disease: acute, subacute, and chronic. Acute, the most severe. We're typically talking about something where you may need to have surgery, you may need to be hospitalized, right? So inpatient care means you're being admitted into a hospital to be cared for in the hospital by a team of physicians, nurses, and other technical people, because of the severity of your situation. Now, you can have, these are acute, typically refers to a severe and well-defined episode of care. So if you have a stroke, right, that initial phase of care is acute, and you'll be treated for a couple of days in the hospital. And then you might be discharged to a nursing home to continue your recovery, because a hospital is only meant to provide you the highest level of care. So if you have a stroke, a hospital would kind of work with you to stabilize you, try to improve your condition as much as possible. And then once they can't do anything more, and it really is a matter of long-term care and rehabilitation, they'll very often discharge you to a nursing home where you move into what we call the post-acute phase, which will be the subacute level, right? So post-acute means you've been treated as an acute patient, and now it doesn't make sense for you to have that level of care anymore. So we're going to push you to a lower level of care. And so a lot of nursing homes now refer to themselves as post-acute care level. So this is less severe typically. And a good example would be rehab after a hip replacement. So if your grandmother falls, breaks her hip, She would probably wind up going to the hospital for a hip replacement. She'd be in the hospital for, say, 48 hours. And then they'd say, okay, we've done everything necessary to kind of get you back on the road to recovery. We're going to now discharge you to a nursing home where you'll receive intensive rehabilitation for the next 3 weeks before you can then be discharged to home, where you might have, physical therapy in the home from a visiting nurses association. And we'll talk about those kinds of organizations. So acute, subacute, lower level. So acute, most severe; subacute, less severe, but still requires care. And then chronic. This is a disease that you have that persists over time. It's not reversible. It cannot be cured. So examples would be type 1 diabetes. There is no cure right now for type 1 diabetes. Maybe in your lifetime there will be, but right now there is no cure for type 1 diabetes. That is a chronic condition. Asthma, chronic condition. HIV, it used to be a death sentence. Now people who get HIV can live decades. One of my favorite podcasters, a guy named Andrew Sullivan, he's recognized as having been the primary force between marriage equality, getting gay rights, and getting forcing the issue to get people who homosexuals the right to marry. So he's a great guy, brilliant. Love listening to him. He contracted HIV in the early 90s, and he's still alive and still kicking and doing great. I mean, I assume he's doing great. I listen to him every week, and he seems like he's doing great. So HIV used to be a death sentence. Now it's a chronic disease. Prior class, I talked about hepatitis C. Hepatitis C, like HIV, used to be a chronic condition. Now we can treat it and cure it, right? So it's not really a chronic condition anymore. So 3 levels of disease states. You should be familiar with these. So, like I said, the United States has historically had a medical model of health, but we're moving, globally in a direction of redefining health as not simply the absence of disease, but an overall state of well-being, right? So physical, mental, and social well-being. So the medical model says, well, if you're not sick, you're healthy. The WHO definition now says health is more than just the absence of disease. It's a positive state, meaning, right, I am generally happy, satisfied with my life. I feel good. I'm in good mental health. That is the direction that we are going in. Now, I want to talk about measuring disability, because this becomes important to defining disease. So there are 2 sets of measures that are typically used to discuss disability. The first one is activities of daily living, or ADLs. And these are very basic functions about whether you can care for provide yourself basic services. So these ADLs include things like, can you feed yourself? Can you bathe yourself? Can you get yourself dressed in the morning? Can you use the toilet on your own? Can you groom, right? So can you comb your own hair? Can you get from your bed to a chair, right? That's actually a big deal. Can you walk a distance of 8 feet? These are pretty low, right? These are not, like, if you're looking at this, I can do all that. Of course you can, right? You don't have it. You're not disabled. Nursing homes use these measures all the time to talk about their residents and determine what level of care they require. So people in nursing homes typically have one or more of these situations where they need assistance. So this is kind of decides whether you need to be in a nursing home or an assisted living facility. So if you have trouble, maybe, being able to dress yourself, but you can still feed yourself, you can still use the toilet on your own, you can get out of bed and move around a little bit, then you might only need to be in assisted living. So somebody, an aide, not a medical person, but just an aide of some sort might come and help you get dressed in the morning, right? That's not a medical. Most of these things are not medical care, right? They just involve getting some help, right? There's no medical care here. So you don't need a medical license of any sort to help people with these things. And some people can live at home with them, right? If they have the support, but it typically says, okay, you can't live on your own if you need care. IADLs are kind of higher level functioning that asks whether you can live independently without any support. So these examples include, do you have the cognitive capacity to answer the phone? Can you use public transportation, or can you drive? So can you get around? Can you shop on your own? Can you make your own meals, right? Can you manage your money, or are you a target for fraud? Can you do basic housework? So these are IADLs. So I think of, and I talked about this in class, I think of ADLs as the world of physical therapy. So physical therapists work on kind of gross motor abilities, like being able to transfer from a bed to a chair. Occupational therapists, and we've got a couple of those in the class, focus on these instrumental activities. Well, they do both. They cross over, do both. So they help. Occupational therapy tends to work on more fine skills, like eating, for example, was one of the ones I talked about. If you have a stroke or if you have Parkinson's, sometimes you get really shaky. And so helping people redesigning utensils, for example, so that people with disabilities can feed themselves is an example of a thing that an occupational therapist would work out. Okay, so we talked a little bit about society and disability and said, in order to society, having a disability requires society to recognize it. And so if you have to get an external, so you have to have a disease, if you will, you have an external social authority evaluate you and say that you have a disease in order for you to be judged by society as having a disability. And if the social authority says, yes, you have a disability, then you may qualify for a variety of social benefits, such as Medicare, for example, right? So Medicare is the program for the elderly, but if you are fully disabled, then you can qualify for Medicare at basically any age. You may qualify for Social Security payments. They're not very much, but they're not zero. If you have a disability, employers are required to provide certain accommodations within their required. It's called reasonable accommodations, and then you may, if you have a disability, you may be able to get preferential hiring benefits. So these are all useful things if you can get society to say, yes, you have a disability. So here's a model coming back to the illness versus disease idea. So we have the illness on top, right? Remember, the illness is the individual and their perspective on themselves. And then disease is society, the social authority saying you have a disease. And what this model shows is kind of three thirds, right? So here in the model, you have illness only, but no disease. So you have a situation where you feel are making, as an individual, are making a subjective judgment that you cannot perform the roles and functions that you need to do because you are not well. But society, in this side, right? Society does not recognize that there's anything wrong with you, right? So the disease, so the social authority over here, these kinds of things, society does not recognize as a disease. And so society is not going to acknowledge that there's anything wrong with you. Basically, this zone is the word you're going to get from society, from everybody else, is going to be suck it up. You need to suck it up and move on. In this third, we have an overlap between illness, between the individual's perception and society's perception. So both the individual and society perceive that there's something wrong with the individual. So this, in our society, that would be cancer, for example. So, you perceive there's something wrong. You're not able to perform your duties. Society agrees, yes, there's something wrong. And so we're going to attempt to cure you of that disease. And then this last third is where the individual doesn't feel like there's anything wrong with them, but society believes there's something wrong with them. So let me give you a couple of examples. In this example, it wasn't all that long ago that homosexuality was regarded as a disease by society. The psychology and mental health use a book called the DSM. And DSM stands for the Diagnostic and Statistical Manual of Mental Disorders. And so this is, if you go to a psychologist and or a psychiatrist and have a complaint, the DSM has a list of disorders that society recognizes, so they're diseases, and definitions of what each of those looks like. So there's a DSM entry for depression. There's a DSM entry for anxiety. There's a DSM entry for schizophrenia, right? It used to be there was a DSM entry for homosexuality. Well, a person who is homosexual may not perceive that there's anything wrong with them. And, from our perspective today, as a society, we would agree, right? And so we would say there is no disease, there is no illness today. But it wasn't all that long ago that the DSM had an entry for homosexuality. And so it was regarded as a disease. So that's an example over here of where society would say there's something wrong with you, but the individual say there's nothing wrong with me, leave me alone, right? In the middle, we'd have things like I mentioned, cancer, a broken bone, right? Things like that, where the individual would agree that there's something wrong and perceive that there's something wrong, and society would also perceive that there's something wrong. And then over here on the far left are conditions that society doesn't necessarily recognize as a disease. A lot of pain conditions fall in here. Pain is a difficult condition to diagnose. So you have a number of conditions like that. You can also think, and I kind of made a joke about this, but you could think of a broken heart. So, most of us, by the time you're in college, and certainly past, have been subjected to, a bad breakup, where someone you really cared about and thought they cared about you turns out that they didn't, and you have a broken heart, and you have trouble as a result performing your duties and roles for a period of time, right? You feel terrible, but society's going to say, suck it up. That's a broken heart. That's not a disease. We don't recognize that. So I'm being a little lighthearted there, but also, aging, for example, right? So I joke, and I will continue to joke about the fact that I'm 51, and I have aches and pains that I didn't once have, and I feel like I can't do the things I once did. I sometimes feel like I have, and I'm sick, right? I feel like I can't do the things I could do when I was your age. Society would say, well, really, that's a perfectly normal condition for being 51, and just be grateful you're 51 and you didn't die when you were 50, right? So those are, so aging, right? Some aging, even though I have a decline in capability, you could say, well, you're still able to meet your social roles. No one expects you to be a 22-year-old anymore. we look at you and we can clearly see you're 51 and we don't have those same expectations. So there is no disease from society's perspective. All right, that's pretty much where we left off. So we'll pick up next time.